All right, our next presentation, Erin Dizon, another senior resident, who's going to be talking about a related issue about, which I think some people were kind of touching on. Is it a myth? Treatment of fever with acetaminophen reduces mortality in critically ill patients.
Thanks, Dr. Freed. So, is it a myth? Treatment of fever with acetaminophen reduces mortality in critically ill patients. This is a cartoon showing a low-grade fever. I don't know if there's such thing as an F+, but you don't want it. So let's talk about acetaminophen. It's called acetaminophen in the US and other countries. It's called paracetamol. It's actually discovered incidentally, like a lot of drugs are. There's two physicians, I think in Germany, that were trying to treat something, and they procured a drug called acetanilide from the pharmacy, which was the wrong drug. But they actually found that it produced some antipyretic effects. However, it also caused blue skin, which was later described as methemoglobinemia. So that's no good. Phenacetin was derived from acetanilide. In the 1950s, it was used widespread, and especially in Switzerland, where they made headache pills, which were a combination of phenacetin, aspirin, and caffeine. And they were offered to nearly everyone. There's studies, or there's sort of anecdotes of these headache pills being given to elderly women in nice coffee shops and to young women working in the watch industry. And the mixtures were regarded as safe, useful, and pleasant. Scientists in Switzerland, after the widespread use of phenacetin, observed an increase in interstitial nephritis in the population of Basel, Switzerland, where a lot of the people consuming analgesics worked in the watch industry after, sort of using their hands all day. And it was only after this paper that worldwide increase of interstitial nephritis was observed, and the connection between the use of analgesics and nephropathy was postulated. So paracetamol, or acetaminophen, is a main metabolite of phenacetin, and it's thought to be safer and more active. And it wasn't after the papers about the Basel watch makers and the connection between phenacetin and interstitial nephritis that paracetamol was starting to be used. So it doesn't cause methemoglobin production, but it does become very hepatotoxic due to its reactive intermediate called NAPQI. So in terms of the metabolism, here's acetaminophen here. 40 to 67% is conjugated with glucuronide, and then 20 to 46% with sulfate, and it turns into non-toxic metabolites that are excreted into the urine, as you can see here. 5 to 15% is oxidized by cytochrome P450 into NAPQI. And from there, glutathione that's supplied by the liver can take NAPQI and form non-toxic metabolites that are then excreted in the urine. But after large ingestions or repeated supertherapeutic ingestions of acetaminophen, all the glutathione is depleted in the liver, and therefore more NAPQI than glutathione leads to lots of highly reactive electrophile product, and it can lead to hepatic necrosis, renal failure, and developmental damage. So the mechanism of acetaminophen is it inhibits prostaglandin E2 synthesis by cyclooxygenase in the CNS and the peripheral tissues. There was a question earlier about the costs of acetaminophen. This is from our Cottage Hospital, the acquisition costs. So as you can see here, the oral tablets are pennies to the dollar, versus the IV, the one that we use is called Ofirmev, which was approved by the FDA in 2010, and it's $28 to the hospital. So you got to think about patient costs. It's usually 10 to 15 times that. That's the cost of the patient, so it's very expensive. A whole day's worth of, think about it, you're giving it every 6 hours. It's very expensive. So let's start with the data. This is a study that Brenda had mentioned by Schulman et al., and it's a prospective trial in a trauma ICU in Miami, Florida, and it included adult patients in the ICU for longer than 72 hours. And they randomized patients to two arms, the permissive arm, which started treating at 40 degrees Celsius or 104 degrees Fahrenheit, and then they started treating in the aggressive arm a little bit sooner, so 38.5 degrees Celsius, which is 101.3 Fahrenheit, and then physical cooling when the temperature rose after that. So this graph is showing the number of infections per patient of those who had a positive blood culture result, so aggressive treatment here in black and the permissive in white, and then also the number of deaths in the aggressive and permissive groups. So the analysis, there was no statistical significance. The p-value was greater than 0.05, but because there was a trend towards death, they stopped the study at 82 participants. Niven et al. Did another study in Canada that was similar to the previous study in terms of randomizing patients to permissive and aggressive fever treatment. The primary outcome was 28-day mortality, and the study found that all-cause mortality was 21% in the aggressive treatment group and 17% in the permissive treatment group. This was not a statistically significant result, however. And this graph is just showing the mean daily temperatures over time. The permissive group here in the solid line and the aggressive in the dashed line, and you can see that the temperature does decrease with the aggressive treatment. Here's two meta-analyses, one by Jeffries and the other by Niven, who has published a lot on this topic, that found antipyretic therapy, including NSAIDs and acetaminophen, was neither beneficial nor harmful in critically ill patients without neurologic injury. This is another study by Suzuki and colleagues in Australia. That was an observational study in 4 ICUs, including over 15,000 patients of both surgical, post-op, and then medical or non-operative patients. 64% of the patients received at least 1 gram of paracetamol, with 90% exposed in the first 48 hours. They looked at in-hospital mortality as well as ICU mortality. This study was interesting because it actually found an association with reduced mortality that was true across the board. So if we look at this Kaplan-Meier survival plot, it looks at patient survival over time. And the closer you are to the 1 on the y-axis, the better chance you have at survival. So the red line is all the patients that received paracetamol, so closer to 1, and the blue line is ones that didn't. And this is a plot for medical patients with infection-related admission diagnoses. However, this was true for all the subgroups analyzed. But when the analysis was adjusted for co-founders, including patients with cirrhosis, if they were looking at IV versus PO paracetamol, different temperature levels, lower Apache 2 scores, which indicates lower mortality risk, or basically lower severity of illness, they found that the association lost its statistical significance. So I want to talk about the HEAT trial again by Young and company. It's a really big study. This group out of Australia is very prolific on this topic. So again, the 700 ICU patients, non-neuro, over 16 years of age, they looked at fevers greater than 100.4 Fahrenheit with known or suspected infections, and they randomized patients to either get 1 gram of IV acetaminophen versus placebo every 6 hours until ICU discharge, resolution of fever, cessation of antibiotic therapy, or death. This is a graph of the study outcomes table. Primary outcome is ICU free days. Some secondary outcomes are hospital free days, days free from mechanical ventilation, days free from inotropes or vasopressors, days free from renal replacement therapy, and also from ICU support. So as you can see here in the red oval, there's no statistically significant difference between the treatment with acetaminophen and placebos. And also, if you look down here at the bottom, they look at mortality at 28 days and 90 days, and there's no statistical significant difference as well. What they did find, however, was that in survivors, I'm looking at this row here, if you were treated with acetaminophen, you had a shorter ICU stay. And in non-survivors, meaning those that died, if you're treated with acetaminophen, you had a longer ICU stay as well as a longer hospital length of stay. And they postulated maybe, these were sicker patients, or they couldn't mount a good immune response, things like that. Again, I just want to reiterate, there's no statistically significant difference at mortality at 28 days and 90 days. But was acetaminophen even good as an antipyretic? So looking at the graph here, we can see along the bottom, you're looking at the study days. This is study day 0, study day 1, 2 and then onward. And here is the biggest difference in the temperature of the acetaminophen group, which is blue, the bottom line, and placebo, which is red. And the largest difference is 0.5 degrees Celsius, which was statistically significant. So although it was statistically significant, it may not be clinically significant for us. So what is this telling us? The majority of the studies that I looked at showed no significant decrease in mortality when treated with acetaminophen. And acetaminophen doesn't really produce a good decrease in temperature. But I don't really want to close the book on antipyretics just yet because there are a lot that we can use. So what about ibuprofen? Is ibuprofen better to decrease mortality rates or to reduce fever? This is a paper put out by Bernard et al. In 1997, and it's a culmination of a bunch of studies by the ibuprofen and sepsis study group. It is a double-blind placebo-controlled trial of 455 patients in 7 centers in North America. And what they found was that ibuprofen significantly reduced the temperature, heart rate, oxygen consumption, and lactic acidosis, but there was no significant impact on 30-day mortality or change in the incidence or duration of shock or ARDS. This is just a graph here showing temperature, and the black line, the black circles is the effectiveness of ibuprofen at lowering the temperature versus placebo, which is this white line, and the gray box is the time at which ibuprofen was administered to the patients. And I just want to bring up 2 additional studies on ibuprofen in 1991 and 2010. Both studies show that ibuprofen was effective at lowering the temperature, but there was no significant difference between the treatment groups in terms of in-hospital mortality. Here are references. Any questions? These are all the examples of fever outside the ICU.
I have a comment about all these studies.
So I just want to repeat the comment for our friends in San Inez, that perhaps a shorter endpoint of mortality would be more sensitive than the longer endpoint. Though I would like to say that the ICU mortality should include all that, right?
Yeah, well, it's shorter. I mean, usually
Yeah.
it's shorter. So some of the studies that she presented actually looked at ICU mortality also. And I think that's a pretty valid endpoint in terms of what you're talking about. And none of those showed an improvement in ICU mortality. There was one that showed a difference in length of stay, but not really outcome.
If you look at some of the data, and I haven't had the privilege of looking at this that intensely, but actually the more successful decreasing of the temperature was in the early days.
Let's see.
Early few days.
So this
Yeah, but it
is-
didn't improve their mortality, it didn't improve their
Well,
outcome.
really, what
So
I'm
yes,
talking
their
about-
temperature went down, but does it really matter?
But if we looked at another endpoint, you might see something different.
Another,
That's what I'm-
another endpoint shorter than ICU stay, length of stay?
7 to 10 days.
Well, that's pretty much what the ICU length of stay would be for most of these patients. Our average ICU length of stay is about 4 or 5 days.
Accept that, but she said
So-
things that it was 21, 30-day mortality.
Well, they looked at those also, yeah.
I take it ICU mortality is defined as dying in the ICU before you make it out?
Correct. Or they don't make it out of the ICU, yeah.
The temperature difference between the treatment group and the non-treatment group is only 1 degree Fahrenheit, half a degree Celsius. That's not much of a difference. So it may mean that if you wanted to find out whether you're doing anything, you have to be more effective at reducing the temperature, because that's trivial.
I mean, that's a good point. So the question was the difference between in temperature of the treatment group versus the placebo group is, 1 degree Fahrenheit. No, I agree. I think more studies probably need to be done to maybe combine the physical cooling plus the pharmacologic to reduce the temperatures even more to see a bigger difference.
This is average temperature.
This is average, and this is just using acetaminophen. This study didn't look at physical cooling on top of that, like other studies have.
I think that it's really a study to know if its effectiveness as an antipyretic would be giving someone the acetaminophen and the placebo, and then 1,000 people immediately notice the difference. It may be that these patients are just the acetaminophen kind of wears off, they're just spiking again, so their average is kind of the
That's
same.
true. Yeah.
Well, I think they looked at the peak as well as the average.
But this chart,
This chart is only
But
the
they
daily
looked at
max.
both.
Yeah.
I think we know from these studies that you get a little bit of the temperature reduction from the antipyretics, but that doesn't really tell you whether it's the result of the temperature increase or the antipyretic therapy that you're getting these very small differences in outcome. I mean, it may well be that the antipyretics are just ineffective.
Well, I think that was one of the points of presenting this, is that the antipyretics
Well, but that,
are not very effective at lowering the temperature, and the ones where they did lower them significantly, it didn't make a difference in outcome.
well, but that's, to say that the antipyretics are ineffective is a different statement than that lowering the temperature significantly makes no difference. I mean, they may both be true, but they're not the same exact conclusion.
Well, some of the studies, I think, in the previous presentation looked at some external cooling as well. It wasn't just, and I think they were probably greater. I personally think that external cooling is much more effective than any of these drugs. And I think a wet washcloth and a fan would be a lot more effective than acetaminophen or ibuprofen for a lot of these patients.
If you go back to the one that I presented earlier with the external cooling and the decrease in vasopressor, they did see that there was a decrease in 14-day mortality, but it was with external cooling, not with antipyretics.
All right.
So there was a difference between 14 days that they saw, but not.
There was a difference at 14 days, but not at ICU discharge or at hospital discharge. And then there was a difference at 48 or at 12 hours for decreased vasopressor use, for getting them off vasopressors faster. But that was only with external cooling and not with antipyretics.
I think there were other questions? Yeah, or comments?
Just one comment. When you're talking about cooling patients, you've got to distinguish between patients whose temperatures are elevated because they have a fever and patients who are hypothermic. If you cool someone who has a fever, they're going to put all their energy to get the temperature back up again because they've reset the thermostat. In pediatrics, it's an incredibly dangerous thing to do. This idea of sponging down children who have a fever when you have not corrected their thermostat, you haven't got down the antipyretics, actually causes them to start to shiver, deplete, and death occurs that way. So it's true, external cooling is very effective. It's probably not appropriate.
I'm not saying that it is appropriate. I don't think it is either. I don't think treating fevers until you get to, personally, I don't really worry about it until they get to 40 degrees. And then I start treating it. Yeah, Bindu.
Out in ICU, you have patients on multiple therapies, right, antibiotics and all of that. How do you take the jump from in a study like that, antipyretic therapy alone, with very little treatments for all comers in the ICU to mortality?
So the question is, how do you tease out all the different medications that an ICU patient is on and isolate an antipyretic in order to do these studies? That's definitely a limitation, especially in this study with ibuprofen, because they found that some people were on acetaminophen for analgesia and not for antipyresis. And, you know, that's definitely a limitation. And that's what we found in our studies as well, that you can't, it's impossible to just treat someone with ibuprofen or acetaminophen because they're on other things.
So you take a single point and then attribute that to especially mortality when people are on different antibiotics and different.
Yeah, I mean, I think that's a problem with all critically ill, all studies, basically, especially critically ill patients. There's a lot of variables, and it's hard to tease out whether any of them are having an effect, but you're not really seeing, for most of these interventions that we're talking about, they try and control for those other things. In some of the randomized controlled trials, they try and control for severity of illness, Apache scores, things like that. But you can't always, certainly you can't always control all of the treatments that each patient gets. So there's always going to be some variability, but we're not even really seeing much of a signal here that there's any benefit, I think. Anybody else have any? It's a good conversation. Okay. What do you guys think? It's time to vote. Treatment with a fever with acetaminophen reduces mortality in critically ill patients. How many people think that helps? How many people think it's acetaminophen is clinically very effective for treating fever in these patients? Nobody? So we'll consider this one busted as well.